Okay, so I'm here with Daniel Harvie today, Dr. Daniel Harvie in Australia. Good morning, Daniel. Although it's afternoon for
Good
you.
afternoon. Good afternoon from my end.
Yes. Thank you for talking with me today. We've not met before, and I came across you recently when we were researching virtual reality and applications in physiotherapy. And we came across your article, your research that you published last year, which was the one on misinterpreting visual feedback for people in neck pain. And we were all quite interested in that. So I had a look at the work you're doing, and it seems like you're doing some really, really interesting work on brain training for, well, I'm going to group it into the word brain training for people in persistent pain. And so I mean, I'm a physio, but I'm also a techie, and I'm really fascinated by, I just think virtual reality is going to be huge. And so I was really interested about the work you're doing from what I can see, and so you can just have a chat to you today. So I hope that's going to be okay.
Sounds great. I'm a bit of a techie as well, so that will suit me nicely.
Good. So before we start talking techie then and start dazzling people, I wonder if you could perhaps just give us a little introduction to yourself, a little bit about yourself, who you are, what you do, and what your work is, so that for people that haven't heard of you or met you before, know a bit more about you.
Sure. Well, thanks for having me. So, yeah, I'm Daniel Harvie. I'm a postdoctoral research fellow in Recover Injury Research Group, Research Centre, actually. So we're a joint project between MACE, the Motor Accident Insurance Commission, Griffith University, and the University of Queensland. So our main aim is to help people recover better from motor vehicle accidents. But the particular arm that I'm involved with is mostly interested in whiplash-associated disorder, which is one of the main problems that comes out of that. So the arm that I'm involved with is led by Professor Michelle Sterling. And I don't know if you know, but we have sort of celebrity rankings for scientists. And when you look up the topic of whiplash, she comes out as number one. So I'm in quite a privileged position here to be working with her at Recover. As you said, my main interest within that is the brain's role in pain that persists, and I'm particularly interested in how we might better understand the brain's role and then target those. And like you, I tend to use the word brain training. I quite like that one. I don't have a better one at this stage. That's a good one. I kind of like to think of myself as a perceptual scientist, really like to understand what pain is and what it is that makes the brain deploy pain. If you think of it in those terms as a protective response that's deployed by the brain to get our attention. Like you, my background is as a clinical physiotherapist, which is where I became interested in pain. I trained at the University of South Australia. I don't know if you know, but that's where Geoffrey Maitland did most of his training. So his legacy still lives on a bit there, but maybe not the legacy that you think. I think he's left a legacy more than he's left it around manual therapy. It's around clinical reasoning and creating thinking and intelligent physiotherapists. So I did my undergrad there and my postgrad clinical masters. So I had some excellent teachers like David Butler, Mark Jones, and Mary McGarry. So very privileged to have studied there. I also did my PhD there. As you would, you hear that Lorimer Moseley comes to town, and the natural thing to do is to sign up to do a PhD. So he was my main supervisor, but I was also privileged to have Susan Hillier, who's a neurophysio, and Dr. Anne Molders, who works with Johan Vlaen in Belgium. So she was a learning psychologist, and the reasons for having her may or may not become clear as we go along. Apart from that, I grew up on a farm. I'm a husband, a guitarist, and a Bernie Sanders supporter.
Excellent. That's a good calibre of mentors that you've been through there. So that's quite amazing that you've been able to work with all those people. So let's start with you talked about the brain deploying pain, and you have an interest in trying to understand that. What knowledge can you share with us about that side of your work?
Sure. Well, perhaps if I elaborate on that a little bit, the main assumption that I work with is that the brain deploys pain in response to it perceiving that our body is in danger. So the obvious signal that the body's in danger is nociception, and of course that's a really important signal of danger. But perhaps, and we have quite a lot of evidence for it now, the brain is also interested in other signals of danger. So they could come from our environment in terms of visual information. They could come through the words written on an X-ray report. They could come through the internet, through the words people tell us, through how we see other people behave, and through our own sort of process of trying to understand our own pain, our own bodies. So I guess I use that as a starting point, and I try to probe those different potential signals of danger. So I don't know if that's a good time for me to actually talk about a study or two.
Yeah,
of mine.
Feel free. Go ahead. Yeah.
You mentioned the virtual reality study. So one of these signals of danger, or if you like, a learned signal of danger, might be signals of movement. So of course, when we have an injury, movement is often one of the things that's associated with pain. So over time, our brains learn to expect pain with movement. Perhaps it might come to want to almost preemptively protect us when we move. So we wanted to investigate that idea, the idea that signals of movement might themselves contribute to or cause pain independent of nociception. And fortunately, as we were sort of working out ways of doing that, there was this huge surge in interest in virtual reality technology, and we were able to get our hands on one of the first Oculus Rift headsets, and we had someone create a software application that would take the amount of movement that someone was actually performing and then magnify it in the virtual world. So we were able to take people with neck pain and have them move a certain amount, but have them perceive as though they were moving much more or much less than they actually were. And we did some checks to make sure that people couldn't actually tell that they were moving more or less than they were in the real world. So the illusion is so powerful that people can't tell that they're being tricked into moving more or less. And so we put 24 people with neck pain into this virtual world, and we subjected them to this exaggerated or understated movement. And what happened was that the point in their movement where they got their pain shifted. So when the visual information told them they were moving more, their pain came on sooner in the movement. And the opposite was also so true. So this to us was a little bit of evidence that the things that become associated with pain become signals of danger that then can modulate when the brain deploys pain, if you like. So that was a really fun study, and and we've also we have this new kind of illusion where we can manipulate perception of movement, and as you say, we're looking at ways that we can apply that as a brain training tool.
Yeah, I mean, this just sounds fascinating. Obviously, as a physiotherapist in the physiotherapy world, this is entirely what we do, is try and get people to move better, move without their pain. Mm-hmm. And just doing that simple thing for virtual reality to come along and allow us to do that and do exactly that, is to change their pain just through a sort of misinterpreting what they're visualizing is incredible. And I think virtual reality is going to have huge applications for pain in the future. I'm really excited about it, and I'm desperate to know more about it. I know the Snow World work was done a long time ago, where they took the burns patients and put them in the snow world and reduced their pain when they were having their dressings changed. Yes. I mean, that's really old, but that working on from there, and what we're working on, how virtual reality is now. And there's also Diane Gromella, who's doing a lot of work on the mindfulness side of things with pain and virtual reality. And I just think it's fascinating. So is there anyone else out there that's doing work now with virtual reality and sort of pain related to movement, similar to what you're doing?
As far as I'm aware, no one's using this kind of a illusion. Certainly people are designing these contexts which might relieve pain for various reasons. And you bring up the snow one, and that shows it's not just a tool for distraction, because they could have used any scene for distraction, but no, they put in this contextual information which is sort of contrary to their current experience. And you might view that snow world as a signal of safety, if you like, in an otherwise very threatening state of being. So my hope is to layer those things, so to be able to layer those contexts with what we can do with this illusion into a therapeutic sort of tool. And that might be starting with really safe contexts and working people towards more threatening contexts. And in the area of whiplash that I'm in at the moment, that might be getting people back inside cars and in traffic and those kinds of things gradually. So, yeah, there's a lot we can do.
Yeah, there is going to be a lot, isn't there? And I mean, I guess the other thing that your study, the study you just talked about, throws up is that it just, it totally reinforces our thinking that it's the brain that's producing the pain and not the movement, because and so it's evidence for that as well, which is really interesting, because again, it's in relation to is specifically in relation to the movement that we see in our patients every day as well.
Yeah, and I think the challenge for us is that we're very wired to see pain with movement, for example, as a mechanical sign and a sign of a mechanical nociceptive component. But I don't think we should, of course, that has to factor into our clinical reasoning, but perhaps we shouldn't jump to excluding other contributors just because someone's presentation seems very mechanical. That makes sense. Because all of those inputs that go with a mechanical stimulus, the changes in sensory input, the visual feedback, the proprioceptive input, perhaps by past association with pain, perhaps those inputs are contributing to the brain deploying a protective response.
Yeah, and I think that's the interesting thing, isn't it? I think that you've brought up just there is that it's not just mechanical pain, that there are so many other sensory inputs as well, like vision, which we've talked about, sound, other senses, hearing. I imagine everything comes into it, and then there must be so many things for us to manipulate there in the future, especially with the virtual reality thing. We've just got the Google virtual reality glasses thing this week, and we've had a play on those, and it's amazing having a look at them. So I'm fascinated to see what other work people are going to be doing with these now that they're becoming more readily available. So what else can you reveal what else you're doing, or what else you're planning to take this research further?
Sure. So I started a study this week looking at using virtual reality to examine those sort of contextual influences on pain. So we've created 5 different categories of scenes. So scenes that are aversive or threatening, pleasant scenes, scenes that are socially positive, and scenes that are socially negative, and some contextual ones. So these aren't just images. We've also created an audible context around that as well. And what we're finding is that the images are powerful, but when you layer on another sense that augments the visual information, we're creating some really powerful scenes. So it's going to be exciting to see what comes out of that. You brought up the Google Cardboard thing, so I've got one of those here so that everyone can see.
Oh, we've got a plastic one.
And this is the exciting thing, is that you've got a plastic one, yeah. So in case people don't know, mobile phones can now become virtual reality displays inside, cheap and accessible headsets. So, we don't make promises at this stage, but it's exciting to think that if we can come up with a brain training tool that physios can use based in virtual reality, it can be deployed by an app store in the click of a finger. So that's quite exciting.
I think, yeah, definitely.
I'm also...
Yeah, definitely exciting.
Yeah. I'm also interested in this idea of sensory retraining or training tactile acuity. I'm not sure if you've come across this, but we have some evidence now that the precision in which you feel touch can be disrupted after persistent pain. And there's a few trials that retrain that ability to precisely detect the location and type of touch. And being interested in tech and making things, I noticed that in these trials, people are receiving sort of an hour a day of this manual training from a therapist where they'll touch a spot and the person will guess based on looking at a picture where they were touched. And this goes on for 6 weeks. And I asked my physio friends who are still practicing whether they do it. And they say they would love to, but they don't have the time to do an hour a day for 4 or 6 weeks. So I thought, well, why can't we create a device that does this? So this is what I'm tinkering with at the moment, and I can show you a prototype. What we've got is 12 nodes, and in the back of those you put what are little mobile phone vibrators. And so you can strap this onto a body part, and then we've created a game on a tablet, and I'm not sure if it's going to fire up, but the game will tell one of these locations to vibrate, and then using our app, people will guess where they were touched, and then they get feedback.
Yeah, clever.
So again, it's one of those brain training tools that actually exists, but is very, very difficult to use clinically, at least in high enough doses that we can drive those neuroplastic changes in the brain.
They look great. I mean, yeah. So, like I said, we've had a play with the Google Cardboard, and they are really accessible now. I think we paid £40 UK sterling. So really, really accessible to many people to get hold of those. And so if you're interested in virtual reality, anyone listening, do get hold of one of those because they are fun to play with. There's not many physiotherapy applications out. Well, I don't know if there are any physiotherapy applications, but there are some medical ones to have a look at. And I really think they're in their early, rudimentary, basic stages. They're all so basic at the moment, but I think things are going to get much, much... In the future, they're going to be amazing. If we look at how gaming's come on and how realistic gaming is now, if we put that sort of gaming development skills into the into what we're going to develop for virtual reality. I think it's going to be amazing, and I'd love to see what you're doing in this study, in your next virtual reality study. I'd love to have a look at your new scenes, but that's going to be difficult, I imagine. They're not available on an app, are they?
They're not available on an app at the moment, no.
Yeah.
But what we're hoping is, we're partway through developing this virtual reality brain training app. And within that, we hope to have a database of scenes that people can select, or that a therapist can select for a patient.
And I guess you're kind of looking at, aren't you, at the more negative, painful scenes to be bringing pain on earlier, and this is speculating, but the hypothesizing, but the not positive scenes and positive social scene and less painful scenes to be reducing people's pain. So it will be really, really interesting to see the outcomes of those studies. So you must keep us posted on how that's going as you can. And then your tactile device that you've developed, that looks amazing as well. That's a really interesting device. It'll be interesting to see how you get on with that and how it can be clinically applicable, whether that's something that patients can use and whether it makes a real difference. That'll be really interesting. What I really like about your work is how applicable it is to the clinical situation as well. It's not just research that's saying, this brain training changes your pain. It's also saying this is how you do it, isn't it?
Yeah. And what's nice about the research environment at the moment is it isn't just about publications. It is about making a real world difference, and the grant applications and things are starting to reflect that. So I think hopefully we'll see more people driving their research towards things that are really clinically relevant.
Yeah. No, go on.
I was just going to say not to disrespect the more fundamental basic science, because that's what we have to do in order to filter things up towards that more clinically applicable.
Yeah, absolutely. We still need the understanding and the knowledge to be able to do the research to develop the clinically applicable tech. Let's say tech that we have the potential to. Yeah. Do these days, and what's coming in the future could be really exciting. It's really exciting. So that's a bit of your research. Are you working on any other research at the moment?
Yeah, I've got a head in a few pies. Yeah. I'm lucky enough to be full-time research at the moment, so that affords me the ability to do a number of different projects. I'm interested in some slightly more fringe theories about how chronic pain develops. So I'm not sure if you've heard of the sensory motor incongruence hypothesis.
No, I haven't.
So the analogy for this is motion sickness, whereby we have this percept of motion sickness when our brain detects a mismatch between the sensory input it's getting and what it expected to get. So if you're reading a book in a car, for example, your eyes are telling you that you're not moving, but your vestibular system and all these other things are telling you what you are. So I don't know whether to view motion sickness as a protective response in that way, but I think you could. It's detecting that there's something wrong in the system, and it's alerting us to it in some way. Of course, after an injury and those kinds of things, the quality of the sensory input could also potentially change. The way it's processed could change because of brain-related changes. And though we don't understand that well, the net result of that could be that there's a mismatch in the system between the information the brain expected to get and the information it actually got. And the net result when it comes to information related to the body or the somatosensory system is that could result in pain. The main evidence we have for this at the moment is if you take people with phantom limb pain and you give them a visual experience whereby their motor commands match the visual information that they're getting. So that makes sense. So they're telling their phantom limb to move, and then they're getting visual feedback that it's actually moving. Whereas normally their motor commands, whether they're subconscious or conscious, aren't matched with any sort of sensory feedback. So that reduces pain in a lot of people with phantom limb pain. Obviously, not everyone has phantom limb pain, but it's not to say that there isn't necessarily incongruence in the system. So the way I'm investigating that at the moment is to think, well, maybe, obviously not everyone's susceptible to motion sickness. So maybe some people have some certain ways of processing sensory information that don't deal with incongruent information the same way that other people do. So I've got a really large survey happening, which I'm about to close, so I can't get you to advertise that for me, otherwise. where we're seeing if people who have persistent or who have developed persistent pain have a greater tendency towards motion sickness, particularly when they were a child before their onset.
Oh, interesting.
So I'm wondering if there could be some overlap between the two in terms of the way that they process sensory information, particularly when it's not normal sensory information. So that one's a little abstract. I'm also interested in...
Abstract, but really interesting. I hadn't thought about that before. I'm not sure other people will have thought about that, how there may... Yeah, some people may be more susceptible to pain because of things like that. Wouldn't that be simple? People that have motion sickness are more susceptible to pain because of a way that the brain sort of uses the inputs, the sensory inputs that it's getting.
Yeah,
that'll be interesting.
And the way it might deal with sensory input if it changes as a result of degeneration or injury and those kinds of things. Yeah, I think the simple fact is we don't have a full grasp of pain at this point, and sometimes you've got to throw a tennis ball at the Velcro and see if it sticks.
Yeah.
So I'm also interested in links between psychological variables and clinical symptoms. So I've got another survey going at the moment looking at a link between psychological variables like pain catastrophizing and the spread of pain. So we already know that it links to intensity, but looking at whether it links to the spread of pain. I'm interested in a phenomenon called spatial summation, whereby if you have nociception from multiple areas, how does that combine to create more pain than either one of those would on their own?
Yeah.
And I think these kinds of concepts are really relevant for example, pelvic pain, where someone might have an ovarian cyst over here and some endometriosis over there and some sacroiliac joint pain over there. And I think these things are all really quite close together. So there's a lot of potential for those inputs to combine at different points of the system in ways that might make several small problems appear like a really big problem. So yeah, that's a bit of a snapshot. I've got too many studies going on at the moment. So I'm in a phase of needing to finish one before I start the next, which is always a hard thing for me to do.
Or you need some research students to help you out.
And I have quite a number.
That's good, yeah. Your work, all of it sounds really interesting. It feels to me, talking to you, like you're taking the pain research to the next level, looking at tech and just sort of expanding on what we already know, which I really like to see. And everything that you've talked about, I'm excited to hear the results of all your studies, which is really good. So there's a lot going on. One of the things that's really interesting, there's two things that I want to ask now. One of the things, one is what I want to say. One is really interesting to hear you talk about so much about the other sensory inputs that have an influence on pain. And it was interesting, I spoke to Mike Stewart from the UK last week, and he talks about that as well. And he uses sensory tactics in the clinic in a different way, just getting people to sort of try and describe their pain or understand their pain through sensory skills like drawing and smell and things like that. So it's really interesting that, you know, that you've both talked about the sensory aspect of pain, which, I mean, I might be far behind the times because people know that I don't practice clinically anymore, so I may not be quite up to speed on things. Yeah, so I'm finding that really interesting, and I know that there will be a lot of other people out there that will be interested in that as well. And then I guess the other thing to ask you is, and I know do you still teach pain science at the university?
I'm not formally teaching pain science. No, I do. I get roped into the odd lecture at the moment, and I do love teaching. But at the moment, I'm reveling in having the opportunity to just dive into the full-time research. Yeah, but I had the privilege of teaching pain science at UniSA with David Butler and the Noi crew and Lorna. So it is a love of mine.
Yeah. So the reason I ask is because I was just going to ask you, really. So as a clinician, as clinicians, what do you think is really important knowledge for them to have at the moment in this day and age to be able to appropriately help people with persistent pain?
One of the things I'm passionate about clinically is understanding the patient's perspective on their problem. Simply asking questions like, what does pain mean to you? And what is your understanding of what's wrong with you? Just with simple questions like that, you can sometimes pull out quite catastrophic understandings that people might have about their problem, that if we hadn't asked those really simple questions, we would not have identified. You know, we can sometimes tackle those really easily, but we actually have to ask those questions in order to find them out. So, of course, we're looking for things there that are threatening beliefs about pain and its meaning in terms of damage, in terms of whether it's going to get worse, so expectations, those kinds of things. You know, fears about being disabled and those kinds of things. You know, without clinical knowledge, usually we've got a good idea about whether someone's body is really in danger and whether their pain is really a signal that they're, you know, in trouble, and we can usually tackle those pretty well. Of course, much more easily if you've done an explained pain course or something like that, where you know, people like Mike and David have become experts in tackling those threatening patient perspectives, I guess. Forgot what your original question was.
Sorry. So just the knowledge that people should have or should be easily able to access to appropriately help people with persistent pain, and you know, asking those simple questions to get an understanding of exactly what the pain means to them is a good starting
so the
point.
First aspect of that knowledge is knowledge of how to assess patients with persistent pain, and then the other is an understanding of pain science, I guess, so that you can appropriately educate people about pain. And then I think as a profession, we're going to pull in more and more understanding of behavioral psychology and how to translate changing people's beliefs and perspectives into changes in how people behave and engage with the world, because you know it's through what people do, through them challenging their past beliefs, through actually doing something, that they really come to a new understanding of their problem and of pain.
And do you think that's going to come mainly from education, educating the patient?
I think good education that's targeted at a patient's specific beliefs is absolutely important. I think I think challenging their beliefs through things like exposure therapy, so exposing them to something that they think is going to harm them as a way of disconfirming that expectation of harm. I think that's going to be really important. And, we had some really interesting experiences with virtual reality whereby when we shared the results with patients, we shared with them that their pain wasn't only dependent on how far they'd actually moved, it was actually dependent on their brain's perception of movement. At least one of those had good pain education, but seeing the results of their test enabled them to really believe what they'd been told. So there might also be some tricks along the way that help to open our patients' minds to new ideas. So, of course, it's really hard. It doesn't matter how much pain science you have. When you hurt, you think that your body's in danger. It's completely innate. So I think we need some powerful tools to get new messages across, I guess.
Do you think the virtual reality is going to do that for us?
That'd be nice. It might. It's certainly a way off. We're adapting this for necks and starting to look at lower backs. Of course, it's more complex to start putting other body parts in virtual worlds and then manipulating it. I'm open to feedback on that. I haven't put my resources at this point into developing it as a clinical tool for that purpose, but I could be convinced otherwise.
How long do you think it's going to be before we're using virtual reality in the clinic?
It's a good question. I'm hoping to release this within a year, so people can start exploring it. We've got a pilot trial planned this year, so we'll have a little bit of data to suggest whether it's helpful or not. We're probably a couple of years off having solid clinical data about whether it's useful. But I don't see any harm in physios having a play as physios often do, and I think we often practice ahead of the evidence. So look out for it. I hope it'll be on app stores within a year.
Well, I'm excited. I'm looking forward to it. Respectful of your time, I don't want to keep you forever, but I just want to take you back to one thing you mentioned a minute ago. We just talked about the knowledge that people need to be clinically effective and with people with persistent pain. We've talked about education and changing behavioural sort of psychology and things, but you mentioned assessment as well, and you started out by saying that we need to understand exactly what people's pain means for them. What are the sort of, just thinking about the assessment side of things, is there any messages in particular that you would give to clinicians to help them be more effective with their assessments?
It's a good question, and I think back to something Jeffrey Maitland used to say. Actually, just sprung into my mind. Not that I've met him, but Mark Jones, who led the Masters, was very strong on imparting Jeffrey Maitland's wisdom aside from his manual therapy wisdom, and one of his sayings was just listen to the patient. So I think of course we have to probe, but I think you can probably get a lot of information from just listening as well. And I think we do, we as therapists, we're always time pressured and we get into our routines of assessments, and so there is some push and pull there in our priorities, but I think there's still a lot to be gained from listening.
So asking appropriate questions and listening appropriately. Yeah, good advice. Okay, we've talked about quite a lot today. I've I've quizzed you on all the virtual reality questions I wanted to quiz you on. We've talked about pain, how the brain deploys pain, and the knowledge that we need to help people with persistent pain. Is there anything else that we haven't covered that you are interested in, are working on, that you would like to share with everyone, or any particular messages that you like to share?
You've drained all my knowledge, Rachel. There's nothing left. No, I would say thank you for having me, though. And, I guess I'd just like to encourage anyone who works in this area. I happen to think that it's the most exciting area that a physio can work in. To quote Lorimer, humans are fearfully and wonderfully complex. And I think that comes out nowhere more than in the field of pain. Of course, it's also a very challenging area, so I think the physios that do work in it need the encouragement. So good on you.
Okay, cool. Thank you. I'm very excited about what's going to happen in the future and all the tech that comes available to us that we might be able to apply into our clinical practice. So I'm looking forward to seeing the results of all your studies. I hope you'll let us know when they're all available for us to read. We'll certainly look out for them and share them, definitely. And just again to say thank you very much for having a chat with us today. It's been an absolute pleasure.
Thanks, Rachel. Pleasure was mine.